Welcome, everyone. We're delighted to welcome you to this webinar, Emerging Lessons from Health Systems Policies and Reforms During COVID-19. Today's webinar is brought to you by Institute for Pandemics at the Dalalana School of Public Health, along with North American Observatory on Health Systems and Policies, and the Health Reform Observer Journal. I'm really pleased to kick off today's webinar. I'm Sarah Allen. I'm Associate Professor of Health Policy at the Institute of Health Policy Management and Evaluation at the Dalalana School of Public Health at the University of Toronto. I'm also the Director of the North American Observatory on Health Systems and Policies, a collaborative research center based at the U of T, but with close collaboration across Canada, Mexico, and the United States. And I'm also the co-editor-in-chief of the journal Health Reform Observer, together with Professor Michel Grignon. This journal is fully open access, peer-reviewed online journal, no reader or author fees. We publish descriptive and comparative analyses of health reforms across Canada to really understand and learn from what happened, how, why, and with what impact. So today, before we begin today's webinar, I'd first like to acknowledge the land from where this webinar is being presented and hosted, and where I sit now. It's for thousands of years, this has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to live and work and play on this land. We're really pleased to have the chance to hear from all of these wonderful speakers today. So I'll start with a few housekeeping items. We have a Q&A feature at the bottom of your screen, which will allow you to ask questions at any time throughout the webinar. But given we have a lot of people to present, we're going to hold the questions until the end. We might not get to every question, but we might have a chance to respond in writing or or to hear from the presenters directly. But please add your questions to the Q&A function. We are recording today's webinar, and we will be posting it on our website at a later date, so stay tuned for that. So before we kick it off, I'm just going to introduce our moderators, who are the guest editors for this special issue of the Health Reform Observer Journal that we're launching and celebrating today. So Professors Cheryl Camillo and Peter Berman will be moderating and introducing the other speakers. Cheryl is a scholar practitioner with 30 years of experience shaping solutions to real-world health and social policy and governance problems. During her career, she served in various roles of the public policy-making process, including Federal Technical Director, State Public Health Insurance Program Director, Policy Researcher, and Program Evaluator. And she's joining us from Saskatchewan, where she serves as an Associate Professor in the Johnson Shoyama School of Public Policy there. Peter Berman is also joining us today as a moderator. He is a health economist with almost 50 years of experience in research, policy analysis, and development training in global health. He's now the Professor Emeritus of Population and Public Health at the School of Population and Public Health at UBC, University of British Columbia, where he was previously Professor and Director since 2019. So I'm going to turn it over first to Cheryl to introduce our first speaker, and then she will turn it over then to Peter after. So thanks so much. Over to you, Cheryl.
Thank you very much, Sarah. I'm very pleased to introduce Dr. Tiffany Fitzpatrick, who's a very engaged researcher. She's a scientist at Public Health Ontario, an assistant professor in the Division of Epidemiology at the University of Toronto's Dalalana School of Health, where Sarah is, and an adjunct scientist at ISIS. Her research program focuses primarily on the surveillance, epidemiology, and modeling of viral respiratory infections like COVID-19 and RSV in pediatric populations, with an emphasis on informing population-based prevention programs, especially those that aim to reduce inequities in child health. And she'll be presenting work she's done on comparative vaccination campaign programs.
Thanks for that introduction, Cheryl. I'm just going to pull up my slides here. So I'm very excited. Hopefully you can see my slides okay. I'm very excited today to talk about work that we did recently comparing the different COVID-19 vaccination programs and rollouts across 4 different provinces. So first, a disclaimer. Some of the things I'm going to talk about today are solely the opinions and beliefs of myself. They don't necessarily reflect our funders, our affiliated institutions, or even necessarily the study team. And on that, I would be remiss if I didn't acknowledge our really amazing study team that put considerable time, effort, and thought into the work that you're very briefly going to see today. But also, they put a lot of work into the 4 pilot studies that underlie the work I'm going to present today. So I really recommend that you go check out those pilot studies. They're available on the COVARNet website. So the motivation for this work was that I think everyone here can appreciate the vaccination programs and the rollout and uptake of those programs varied substantially across the provinces. Now, there might be very many different reasons that would explain this, but yet no study had started to understand how potentially the design and implementation of those programs might have impacted uptake. So our focus was on the primary 2-dose series in adults, and particularly in that first year of the rollout of the vaccines. So we conducted 4 case studies looking at British Columbia, Saskatchewan, Ontario, and Nova Scotia. And these were all externally reviewed case studies reviewed by local experts. We adapted a framework that was developed by the the World Health Organization. It was their COVID-19 response monitor template, and it looked at these 6 factors. Now, in the interest of time, of course, I can't get into all of them today, so just going to give you a little snippet of some key items. And we scoured all the different available public documents, media reports, briefings, and so on, but we also included unpublished materials and communications from our local experts. Following the 4 case studies, we conducted a cross-case analysis to identify key similarities and differences to potentially identify promising practices and lessons learned to inform future vaccine campaigns. Now, one of the most notable differences that we observed across these 4 provinces was in the governance and implementation of their vaccine campaigns, and particularly in how centralized they were and the degree to regionalization. So in BC, even though they have 6 regional health authorities, it was still very clearly centralized through the province. In Saskatchewan, it was also very centralized all through the 1 provincial health authority. And similarly in Nova Scotia, they also have 1 provincial health authority and also the IWK healthcare system there. Now in Ontario, things were quite different. So in Ontario, things were extremely decentralized in terms of government implementation and a range of things you'll see later in the slides. Uniquely, Ontario has 34 public health units. So they were actually given some level of autonomy and flexibility in how they rolled out the provincial plan, which allowed them to adapt their strategy depending on the needs of their local populations. Also unique to Ontario was that there was a high level of regionalization. So not just within public health units, but also getting more refined. So a unique thing in Ontario was the implementation of a hotspotting approach. So week to week, it was assessed whether their specific communities were experiencing exceptionally high levels of COVID transmission and disease, and people living in those populations were actually given advanced eligibility for the vaccines. Another factor that was unique to Ontario that we didn't see in the other 3 provinces was that there were many communicators. So in the other 3 provinces, communications to the public regarding vaccine eligibility and other factors were primarily through the Premier, the Chief Medical Officer of Health, or Public Health Officer, or potentially the Minister of Health. In Ontario, there was all of those, but also other forms of government, public health and healthcare officials, and also others that were not a part of the formal governance structures. And in particular, there were several different types of tables and advisory bodies that were also informing the public in Ontario. Okay, what about the booking systems? Very similar to what we saw on the last slide. So in Saskatchewan, things were pretty centralized. So they had 1 system for all the vaccines that were being done through the province, but each individual pharmacy brand had their own website that people could book through. In Ontario, things were pretty disjointed. So initially, each of the public health units had their own booking platform. Eventually, most of those moved to a provincial platform, with a few public health units still offering it through their own websites. And again, each individual pharmacy had their own platform. In British Columbia, things were very centralized. So they had 1 for the province and 1 for all of the pharmacy. So it didn't matter which pharmacy company you were going to, it was all coordinated through the BC Pharmacy Organization's website. In Nova Scotia, things were extremely central. So it didn't matter where you were getting your vaccine, you had 1 website to go to, and it was very clear that's where you booked your vaccine appointment. We also saw that there were notable differences in the coverage goals and how explicitly those goals were communicated, but also the levers used to achieve them. So at a very high level, all of the provinces were trying to vaccinate as many people as quickly as possible as they could. Now, this wasn't explicitly mentioned in the plans for most of the provinces. It was explicit in Nova Scotia's plan. They also were quite explicit in that they had a coverage goal. So in Nova Scotia, the goal was explicitly to vaccinate 75% of the eligible population by September 2021. Now, while most of the provinces tied these different coverage goals to the reopening and relaxation of public health measures, Nova Scotia was uniquely steadfast in this. So they actually delayed reopening until this goal was achieved. And this was even within the context of a turnover in their premiership. You'll see here, it was loosely tied to reopening in BC and Ontario. Saskatchewan actually decided to reopen before they had reached a previously communicated goal. So now I just want to very briefly again give you a deeper dive into two of the provinces we looked at, and specifically two of them that are very different from one another. So in Ontario, we had this situation where things were highly decentralized across all aspects of the vaccine rollout. So leadership, booking, governance, what have you. So each of the 34 public health units were more or less kind of doing their own thing. There was the Canadian Armed Forces overseeing things in the north, many different booking systems, lots of different governance and different advisory tables. And what we saw in the media was that it was often described as a labyrinth. It was Hunger Games. So there was this very clear idea in the public that it was very hard to find a vaccine appointment. You know, you kind of felt like you had to kind of game the system. Maybe if you go to one public health unit, you might be able to get your vaccine appointment earlier than if you went to another one. You kind of had to be in the know to figure out, you know, what was the best approach and make sure you got your appointment. Now, thankfully, there were many effective grassroots organizations and public health led initiatives to promote uptake and equity to their specific population needs. And I just want to flag one of them, the Vaccine Hunters. So they were very active on social media, letting people know where there were vaccine appointments in which public health units, which clinics, and so on. But as you can imagine, this might have had some equity impacts because of who is online and who's available to go to a same-day appointment, and potentially if that involves travel to a different city. Now, Ontario also leveraged its very expansive pharmacy network early. However, given that there were the different booking platforms, this did cause some headaches. Also, there wasn't always a vaccine available for each of those appointments. That means sometimes appointments were canceled very last minute, or people didn't show up to their appointments because they found out that that day it was providing one type of manufacturer, but they wanted another, something called vaccine shopping. So it wasn't the most efficient or stress-free way to get your vaccine. Now in Nova Scotia, we saw something very different. So everything there was very centralized. And I'm sure a number of people on this call are probably familiar with Can Immunize. So Nova Scotia contracted this Ottawa-based company. They could coordinate all aspects of the rollout through this. Uniquely, it also gave them real-time data. So it meant when someone booked their appointment, there was actually a vaccine tied to that appointment, and it was sitting there waiting for them at the clinic. So there was no last-minute cancelizations. They also had pharma included in that. So, you know, there wasn't this Hunger Games approach. Everyone was booking through the same means. However, you know, it wasn't without its hiccups, and it was often slow to adapt this, you know, large machinery. And again, this was reflected in the media. You know, it was highly lauded, this whole approach. You know, why don't other provinces have this, and so on. But again, it's hiccups. So, you know, it did crash when there were a lot of visitors on a particular day. Also unique was that Nova Scotia had really stable, centralized, experienced leadership that was a regular face for communications. They had those clear goals that they were steadfast to in achieving. And again, you know, they were also a little bit slower to start, but then they did quickly pick up the pace in their coverage and were, you know, one of the leaders across the provinces. We have this really nice timeline in the paper that I won't get into here, but recommend you check it out. But just to flag that regardless of these differences, we saw that all 4 provinces achieved 50% coverage with the first dose in adults, more or less around the same time. This was a little bit different when looking at 75% of coverage with 2 doses. So Saskatchewan achieved that goal a little bit later than the rest. Now, what are the main takeaways? So we did see some differences, and you know, these differences might have had some influence on the time to achieve goals. But we saw, you know, in the case of Ontario and Nova Scotia, very different approaches, but yet they achieved milestones around the same time. So what I think the biggest impacts were likely on was ease of access, equity, our ability to reach hard to reach and vulnerable populations, ability to reach vaccine hesitant people. If you're hesitant, you have all these hoops to jump through, you know, you're probably not going to get vaccinated. trust in public health, and particularly how fair people thought the rollouts were. And another big one, public confusion. So I look forward to taking your questions after, but feel free to send me an email otherwise. Thank you.
Thank you very much, Tiffany. I look forward to the discussion on this paper. Peter will introduce our next presenter.
Okay, thank you, Cheryl. And our second paper, the Restoration House COVID-19 Vaccination Clinic, Challenging Systemic Racism and Ableism Through Community Solidarity and Action, will be presented by Professor Emil Joseph. He's an associate professor in the School of Social Work at McMaster University, currently holds the professorship in Equity, Identity, and Transformation from the Faculty of Social Sciences at McMaster University, and is the academic director of Community Engaged Research and Relationship with the Office of Community Engagement, also at McMaster University. He draws on perspectives of critical forensic mental health, MAD studies, post-colonial theory, critical race theory, and critical disability studies to analyze the historical production of ideas about difference, normalcy, sexuality, eugenics, race, ability, and mental, in quotes, illness, as they cohere, diverge, interdepend, and perform within policy, law, and practice. Professor Joseph, please take it away.
Thanks, Peter. All right. Thanks for having me. I'm going to try and give a kind of 10-minute synopsis of the story of this work and this paper. I know there's a lot going on in the world right now, and hopefully by the end of this talk, you'll see what I see and do and share my feelings of hope. I think there is, oops, one second here. Having some trouble.
Your slides were not advancing?
I think the images weren't working. I think I'll try again.
Because we saw your slides. We can see them now.
Can you see the images on this slide?
No. Sarah suggests using a PDF.
How about there?
Yeah, now you can see it. Yep.
Great. Okay. So I think there's an appreciation that racism in healthcare in Canada is a pervasive issue. It's a topic that has found its way into the public media and government, and this is a time when we should be taking more action than ever to address it, in my opinion. Canada has its own unique histories of race, racism, racialization, and colonialism that we often don't acknowledge in the dominant ways we talk about history. You know, when I was coming up in education systems myself, we rarely talked about residential schools in Canada or how South African politicians came to Canada in the 1940s to learn from our racism in the Indian Act, or how to use status cards and the reserve system in apartheid in South Africa. It would take me, you know, several weeks to talk about Chinese head taxes and Japanese internment, turned away ships of South Asian and Jewish people, chattel slavery, black settlements erased, and how those histories frame civil and social relations in health policy and practice and law in Canada today. In my research, I've traced some of the historical pathways that discriminatory ideas have shaped mental health, criminal justice, and immigration policy and practice in Canada. And Often these racist ideas took hold many years ago. I think our job is to think about how those ideas have been divorced from their original projects, yet continue to operate with similar outcomes today, how they operate within professions and disciplines and practices and policy and law, and how we think about capacities and capability and excellence and threat and burden and risk in racialized ways. So this isn't about having people identify as a bigot or feel guilty. That reaction all too often comes from a place of privilege that often undermines our work to listen to those who experience racism and for other forms of discrimination and act in accountable ways to respond to our complicities. These matters are very local here in Hamilton. You know, we've ranked in the top 3 in terms of per capita police reported hate crimes for several years. We've had some significant hate-based atrocities occur in Hamilton, including arson attacks on Hindu and Muslim places of worship and racist symbols found in synagogues and ongoing issues with racial profiling and policing. And all of these contexts have historical roots. The KKK were well established in this area. The histories of Black settlements and slave training in Hamilton are often omitted in the tellings of histories of Hamilton as well. I often tell the story of Hat Street in Dundas. This book in the center tells the story of Sophia Pooley, who was purchased along with her sister by someone named Samuel Hatt from the indigenous leader, Joseph Brant, both of whose names line our streets, our towns and institutions today, often without recognizing the racism behind these stories built around us. I raise these contexts because I feel like they're not named enough in how we talk about contemporary health inequities, and these contexts permeate our systems and services and programs and disciplines. And we've seen quite a few reports, we did see quite a few reports that share racial disproportionalities as just that, often without an embedded analysis that even surfaces the problem of the racial histories of blame, the portrayals of types of people as threat or burden, infused with racist ideas of hereditary, cultural, or aptitudinal lack. We saw quite a few examples of this in the ways racial disparities were depicted in relation to COVID-19 infection rates. In Hamilton, it was October 2020. We were seeing that some 50% of COVID-19 infections were among racialized populations here, and there were calls for more race-based and socio-demographic data collection to get a better sense of the disparities. In May of that year, a group of doctors and professors and community leaders with experience and interest in equity work wrote to Hamilton Public Health. We recommended that any collection and analysis of race-based data, including the processes and methods of collection, were developed collaboratively with local leaders and experts who live and do anti-racism work and research and analysis. So we recommended the establishment of a community advisory committee to structure this into a supportive, responsive, engaged, inclusive, accountable approach to responding to health needs in Hamilton. And these aren't new conversations. Many have written about the problematics that rely on the collection of data to convey action, where old relations and inequities and injustices are not only maintained, but in fact solidified. Professor Ronaldo Walcott wrote recently that there are indeed some truths about calls for race-based data, but there are many half-truths too. Evidence is important, and few would dismiss evidence as unnecessary. However, race-based data can quite frankly slow down reform. In that context, doing research when a problem is already identified and its solutions known means that the collection of race-based data does not actually add much to policymaking. In fact, in some cases, it can do more harm than good. Race-based data collection, as currently articulated, is a response to a set of political concerns masquerading as if it is the answer. Wanda James reminded us that personal information, including health data, has to be protected, whether it's identifiable or de-identified or anonymized, and laws, regulation policies, and substantive enforceable penalties are the minimum preconditions that must be in place before more race-based data is collected and circulated. So that group that wrote the letter broadened, had meetings with public health, developed terms of reference for the group. We did so on our own time, evenings and weekends for nothing. We applied for a seed grant with the McMaster Institute for Health Equity to help launch our research. We made it clear that we believe in the need for people to be involved in how they are identified, how they are described and analyzed, to allow for transparent data collection and analysis. And we believe that community feedback, insight, and analysis needs to be empowered with the authorities to affect change. And we raised issues around the categories being used, issues of data ownership, access and control and possession. We submitted that in July and didn't hear a response, so we went public. Largely, the analyses and perspectives and rationale were ignored. So we continued our talks. We held panels to raise these issues with the Vaccine Readiness Network that began in December of 2020. So it was a committee of health and community leaders who worked with Hamilton Public Health to think about priorities for vaccination. And I was invited through various channels through my work with the Hamilton Center for Civic Inclusion and the Disability Justice Network of Ontario. And many community leaders took the opportunity on the Vaccine Readiness Network to ask how public health was addressing the disproportionate rates of infection among racialized groups in Hamilton. We took our own action when much wasn't changed. We wrote a letter to the network and to public health, letting the need for change. We had 500 Hamiltonians sign in support of it. We got some media attention after that. There was a growing group of Black and other racialized community members and leaders that served marginalized populations that rallied in solidarity to take on the work to establish clinics that were prioritizing those most affected. And Black and racialized health leaders and community orgs, myself included, began to develop plans to address the needs. Public health agreed to prioritize our priorities. So we had all of the community health centers in Hamilton work together with a couple of community organizations. Dwa Desne was the Aboriginal Health Center and the Hamilton Regional Indian Center. They also set up a clinic alongside the Restoration House Clinic to serve those most in need. As soon as the news hit the public, racist social media trolls heard that the clinic was prioritizing Black and other racialized people for vaccination. And we began to receive torrents of hateful messages. So the initiative was targeted on extremists and white supremacist websites. It was a really difficult time. In the early days, there were ways to book through the City of Hamilton booking system and the phone line. And community agencies themselves were doing their own booking system and outreach manually. We created our own booking system when we transitioned to primary care, and that had the most success. The initiative was led and run by community health centers, community leaders, and organizations. They developed plans and mobile clinics and numerous locations and disseminated information through in-person outreach and online and social media in numerous languages. They had special clinics for those with disabilities, made clear that health cards weren't necessary, and thousands of people in Hamilton had been receiving their vaccinations through that initiative. And I personally received emails and messages from individuals and families that shared their gratitude for the clinic and stories about having such a great experience that they all, their families and their extended families were able to access vaccination through the clinic. And it continued through walk-ins at the Hamilton Public Library. The solidarities and relationships built here began through collectivity and resistance. They merged through advocacy and they stayed focused on need. And this is the kind of story you might not see that often or spoken about as media pick up bits and pieces now and again. I began by speaking about the ways that these times can definitely be described in terms of hurt and all we have lost, the harms that continue, and the devastating context of systemic, historical, and contemporary inequities. I could probably give another talk on the systemically racist practice of undervalued labor of Black and other racialized health and community leaders and community members, the erasure of their contributions, and the systematic ignoring of their ideas. But I'll leave that for another time. What I hope for today is for folks to see just that hope. It would be easy to think about this work in oversimplified terms, that this work was about collecting race-based data or separate services or representation. I believe that kind of analysis undermines the beauty that we saw here in Hamilton. Thank you.
Okay, thank you, Camillo. And let me now hand it back off to Cheryl to introduce the next paper.
Thank you. Our next paper is from Dr. Nancy Cote, who's an associate professor in the Department of Sociology at the University of Laval. She holds the Canada Research Chair in the Sociology of Work and Healthcare Organizations, and is also a member of VTAM, which is a Sustainable Health Research Center, where she is the co-leader of the research theme Environment, Living Environments, Work Environments, and Care Environments, which includes regional and rural environments. And as you'll see reflected in her paper, her research focuses on the transformation of healthcare organizations and their effects on the work of professionals and managers in the healthcare sector. She's particularly interested in innovations in primary care and social services, such as governance and leadership, and new models of collaboration and redefinition of professional roles. I look forward to this presentation.
Thank you, Cheryl, for the presentation. For the introduction, I'm going to try to share my screen. Yeah. Can you see it? Yes?
Yes.
Okay, thank you. So our article aimed at examining how existing primary care services were transformed in Quebec during COVID-19 to better serve the most vulnerable individuals and in particular those with mental health challenges and family in vulnerable situations who have been disproportionately affected by the pandemic. So these are my colleagues and co-authors, and the project was founded by Cheryl and VTAM, my research center. As you know, despite numerous reports emphasizing the importance of primary care, Quebec's health and social services system, like many other jurisdictions, has historically favored a hospital-centric system with resources concentrated in acute care facilities. So primary care has always taken a backseat. And even before the pandemic, we know that certain clienteles in vulnerable situations had more difficulty accessing primary care services. So with the pandemic, these difficulties were exacerbated, as were the number of people in vulnerable situations. So it was against this backdrop that we set out to document the evolution of primary care services, to grasp how the primary care sector was changing to enable more equitable access for people in vulnerable situations, and also to enable services to better adapt it to their needs and the complexity of their situation. So the aim of the project was to gain a better understanding of the conditions under which innovative practices, or what we termed as rapid reforms, emerged and become sustainable. And here, innovation is defined very broadly. It refers to clinical and organizational practices, new modes of collaboration, privileged form of leadership, and digital health. And I put innovation in quotation marks because it's important to say that most of these practices were already in a pilot stage before the pandemic or were under development. And the context of the pandemic meant that these practices were ultimately the best suited to reach the populations most affected by the crisis. The practice documented were deployed in one Centre Intégré Universitaire de Santé et de Services Sociaux, CIUS in French. The mandate of CIUS is to provide primary care and social care to the population in their respective territories. So as part of this project, we have identified various practices that were developed during the pandemic. We don't have time today to describe all these practices, but here are some examples. The second one, convalescent center and establishment of a homeless liaison team. They were created to provide a safe roof over the head of homeless and precarious people, a practice that required increased coordination and collaboration between several key actors located in a shared space. So collaboration between providers from CIUS, the community network, and the police. And the third one, outreach clinician deployment. The practice aims to deploy clinicians in living environments to promote community empowerment and facilitate access to services to population who did not typically seek services. And it involved partnership between CEOs, the local community, and the network as well. So to grasp the conditions under which the innovative practices emerge, we have drawn on the framework of Van Gensel and her colleagues, who emphasize 3 dimensions of particular importance for understanding the implementation of reform. The first dimension is timing. The timing at which a change is implemented will make a big difference in how the change project is received and its ability to be deployed. The second dimension, ideas and interest. So in organizations as complex as health and social services, there are always many coexisting ideas and interests. Some ideas are more marginal, others dominant. And this framework focuses on how certain ideas or practices come to prevail and acquire legitimacy within a given institutional context. And this is third dimension, the importance of the institutional context. And for these ideas to gain legitimacy, it takes a network of actors at different levels of the system who support these ideas so that they can take root. So this it was with this framework that we analyzed our innovative practices. So now the results, so the key messages, I would say. First, leadership. The way in which leadership has been exercised in implementing these rapid reforms is an important element characterizing these innovative practices. So the unprecedented nature of the situation and the lack of certainty as to the solutions to be put in place created the right conditions for more shared leadership between the various actors within the organization and with local partners. So no one had ready-made solutions. Middle managers, professionals, and project managers who would not normally have been involved at a strategic level played a leadership role in implementing these practices at different times. These practices are also characterized by a more diversified, sustained, and structured collaboration between the different management departments and the various local partners. So intersectoral collaboration are marked by more egalitarian relation between the healthcare organization and local partners, and there is a greater appreciation of each other's expertise and effort to optimize complementarity. So it's a new way of working together, but a new way that takes time. Finally, the boundary people. Innovative practices have been deployed with the support of certain key people, what we call the boundary people, who have shown strong leadership in the implementation of these various practices. Boundary people refers to the agency of certain individuals who played a particularly important role in the implementation of the practices. And these individuals have a hybrid profile of training and experience that, that enables them to navigate between different worlds, to negotiate between sometimes divergent interests, and to find ways of moving between the different institutional logics in order to advance the projects. And as innovative practices rely heavily on cross-sector collaboration, boundary people play an important role as intermediaries between the various organizations involved. So in conclusion, the key messages, the COVID-19 pandemic created a window of opportunity for greater policy recognition of the importance of primary care services, the need to react quickly and to develop new ways of organizing primary care services to reach more vulnerable individuals, fostered a greater tolerance for risk, encouraging experimentation, innovation, and allowing some non-mainstream practices to gain legitimacy in the context of the pandemic. The rapid reforms pertaining to mental health and families in vulnerable situations were situated within a more sustained and structured and intersectoral collaboration based on the valuing of complementarity and of expertise of various sectors. However, vigilance is needed to avoid a return to previous ways of doing things, particularly with respect to collaboration, leadership, and mobilization of frontline workers. Also, labor shortages are an important issue to consider as they can impair primary care's ability to innovate. So thank you, and I'll be happy to answer your question.
Thank you very much, Nancy. Peter will introduce the last paper of this webinar.
Thanks, Cheryl. So the last paper, Expanding the Scope of Community Pharmacy Practice in Nova Scotia, Impacts on Provincial COVID-19 Response, will be presented by Tasha Ramsey. Tasha obtained her Bachelor of Science in Pharmacy degree in 2008 from Dalhousie University, her pharmacy residency diploma in 2009 from Kingston General Hospital and the University of Toronto, and her postgraduate Doctor of Pharmacy degree in 2013 from the University of British Columbia. Tasha is the Emerging and Re-emerging Infections Clinical Therapeutics and Prophylactics Lead for Nova Scotia Health and an Assistant Professor at Dalhousie University's College of Pharmacy. She's a member of the Nova Scotia Emerging and Re-emerging Infections Network and co-chair of the Nova Scotia Emerging and Re-emerging Infections Therapeutics and Prophylactics Recommendation Group. Over to you, Tasha. Thank you.
No, thank you so much for having me. So I'm going to discuss the expanding scope of community pharmacy practice in Nova Scotia and really how we contributed to our provincial pandemic response. But before I do that, I want to acknowledge that I'm just one author within our team. So this is really on behalf of Ingrid, Jennifer, Chiranjeev at Dalhousie University, and also Andrea Bishop at the Nova Scotia College of Pharmacists. So I encourage you to check out our paper. It's 20 pages in length, so this will certainly be just the highlight reel. We're going to very briskly walk through the outline here. You'll see that we'll talk about background information, the goals of the reforms, what the reforms were, a SWOT analysis, and the conclusions. So if you're not familiar with Nova Scotia, we recently passed 1 million people that live in the province. And in Nova Scotia, primary care is mostly delivered in a fee-for-service model by family physicians. And despite efforts to really improve access to primary care, pretty consistently for the last few years, over 10% of our population does not have a primary care provider. And so to improve this access, the province is really exploring ways to involve other healthcare professionals in offering primary care. And when it comes to community pharmacy participating in this, Nova Scotia has 1,500 pharmacists, 246 pharmacy technicians, and 315 pharmacies. And we're thought to be pretty accessible in Nova Scotia because 80% of the population lives within 5 kilometers of a community pharmacy. Another thing that helped us help out with the pandemic is the fact that we had established cold chain procedures. Other things that helped were the fact that we already started expanding our scope of practice prior to the pandemic. So you can see back in 2011, pharmacists gained prescribing privileges. And in 2013, they were able to administer drugs by injection. And they've really embraced this responsibility over time. And that was seen in 2019 when pharmacist immunizers were the leading immunizer for influenza vaccines. And then as we encountered the pandemic, we know that community pharmacies remained open even during lockdown periods. And they became a really critical source of primary health care. So not only did the front store have toilet paper when that was a hot commodity, but they also offered medication and vaccination services, PPE, hand hygiene solutions, thermometers, pulse oximeters, and more. So the reform goals were really just to bring the full extent of the pharmacist's knowledge and skills to meet the patient's needs. And what this looked like was really leaning into their medication expertise. It also looked like trying to have them help address drug therapy concerns for both acute and chronic medical conditions, and also helping to navigate drug shortages that were resulting from pandemic measures. And finally, we're also hoping for them to really increase the uptake of COVID and influenza vaccines. So when it comes to the reforms related to prescribing, I've indicated in blue text in the top of the slide really what foundational things have to happen before these reforms can really be robustly implemented. So when it comes to expanding scope of pharmacy practice in Nova Scotia, we have to gain the ability to expand our scope through adding things to our standards of practice. And then to have these services publicly funded, the Pharmacy Association of Nova Scotia submits the service for consideration through tariff negotiations through the Pharmacy Services Agreement. Then only once they're added to the Pharmacy Services Agreement does the province pay for the services. So we've already outlined how over time and before the pandemic, we were really expanding our scope, gaining the ability to prescribe as pharmacists. In 2011, what this started out with was really prescribing for minor ailments. And then in 2019, just before the pandemic set in, additional things were added as well. So prescribing for things like shingles, cystitis, and contraception, in addition to also being able to extend prescriptions for up to 180 days. And finally, pharmacists were also able to prescribe when a diagnosis was provided and they were collaborating with a primary care provider. But really, when the pandemic happened, things really started to expand even further. So we were able to renew prescriptions with no time limit. We also gained the ability to do some prescribing for narcotics, controlled and targeted substances, and we're involved with prescribing for the treatment of COVID-19. So during the pandemic, when there was a lack of access to traditional primary healthcare sources, there was a big change that happened from Health Canada's subsection 56. There was an exemption issued in October of 2020, and this allowed pharmacists to prescribe narcotics, controlled and targeted substances for the first time. Nova Scotia then also responded from the College of Pharmacy and put out an emergency protocol to help with this prescribing and to put in safeguards, and then later formally put it into the standards of practice. And when it comes to COVID pharmacotherapy, in May of 2022, the standards of practice were updated again, and this was to allow pharmacists to prescribe for drugs and treatments for COVID-19, specifically when they participate in a public health initiative directed by the provincial government or a provincial health authority, and it also had to be in accordance with protocols or guidelines established by the province or the provincial health authority. And if you're wondering how pharmacists took up these responsibilities, you can see in the blue box on the right, all pharmacists are able to prescribe for inhaled budesonide, and we have a group of designated pharmacist prescribers that are prescribing for nirmatrelvir, ritonavir, and remdesivir, so our antivirals that we use for COVID-19. When it comes to the antivirals, we set up a process as of March 2022 where patients or their care providers or healthcare professionals, but mostly these referrals come from patients, they place their referrals through something called the report and support form. So this is available online. And what happens is that they can complete it online or call a phone number to have someone help them do it. We ask them to complete this to be assessed for the antivirals that require a designated prescriber when they have a rapid test that's positive or when they book their PCR. This information then flows over to our COVID-19 non-severe therapy team. So this was initiated back in March of 2022, and it's staffed mostly by pharmacists. So you can see that we have 3 to 5 pharmacists on per day, 7 days a week, and 1 physician with expertise in COVID that's also working with us 7 days a week. This team has been very busy, you can see from this slide. So we have accepted over 100,000 referrals to date, and we've gone through with the processes of using automation, also manual screening, and assessments, caring for these individuals. I've highlighted in the bottom green box the fact that the designated pharmacist prescribers on this team prescribe 97% of prescriptions that come out from this service, including for nirmatrelvir, ritonavir, and remdesivir. Finally, when these prescriptions go to community pharmacies, the community pharmacists also receive a special fee for doing some follow-up related to these medications. So in particular for nirmatrelvir, ritonavir, they get an extra $3.50 from the provincial government just if the patient calls back with further questions or if they were to start a medication during their 5 days of treatment to be assessed for drug interactions. So we've created an assessment protocol for the pharmacist to use. So that's provided on the right, you can see it. Just highlighting once again, we do have designated prescriber pharmacists that are prescribing nirmatrelvir, ritonavir, and the community pharmacists offer ongoing assessments. Next up is inhaled budesonide. So in May of 2022, when the college enabled pharmacists to prescribe for COVID therapeutics, this also enabled them to prescribe for inhaled budesonide for mild respiratory symptoms of COVID-19. Shortly after that, on May 9th, our provincial government implemented a fee of $20. So there's public funding for the pharmacists to do these assessments and to do the prescribing. You can see on the right the prescribing protocol that the pharmacists use. And just to clarify once again, any pharmacist in Nova Scotia can prescribe inhaled budesonide. And then when it comes to vaccination, a huge thank you to Tiffany, who went over some of the details on this slide. So hopefully I can be a bit quicker here. But for pharmacists to provide vaccines in the province of Nova Scotia, they have to complete necessary training, and they also have to get a permit to administer drugs by injection. Pharmacists in our province were involved with our vaccine campaign for COVID-19 from the very beginning. So they started helping out in December of 2020. We do use the centralized booking system that Tiffany outlined called Camillo. And our provincial government was reimbursing the pharmacists for providing these injections, initially $16, and that bumped up to $18 in April of 2022. And I also want to note that although we were involved since the very beginning, we really took over the provision of COVID vaccine provision in August of 2021. And that's because at this point in time, our mass immunization clinics shut down. And what's been stated to really help the pharmacist in taking up these COVID vaccine activities is the fact that they receive advice from multi-stakeholder committees, including our vaccine expert panel and the COVID pharmacy planning group, which consists of our association, the Nova Scotia College of Pharmacists, our Department of Health and Wellness, and groups based out of Nova Scotia Health as well that provide recommendations and also further advice on how to care for individuals with COVID-19. Another essential piece of support that they cite is the ability to have peer support. So when we made that transition back in 2021 and shut down the mass immunization clinics and COVID vaccination moved to community pharmacies, they did cite the need to have a peer support network. So we started the vaccine consult service, which at the time was called the COVID-19 Vaccine Consult Service, and we've since expanded out to all vaccines. But regardless, you can see that we've answered over 4,000 phone calls, predominantly from community pharmacists, and we answered those calls in real time, 7 days a week. And when it comes to the evaluation, you can see that at the time of us submitting this paper, there were a few things that were out there and published from Nova Scotia. So one thing was an electronic survey of self-reported prescribing patterns, basically just before the pandemic and during the early days of the pandemic. And you can see that high frequency pharmacy prescribers increased from 50 to 80% during the early months of the pandemic. And also you can see the provincial government paying out more for these pharmacy services. There was increased uptake. So basically it went from public reimbursement from 28% up to 80% during COVID. We can also see that the monthly prescribing averages have been increasing consistently over time. And in one study examining our community pharmacist response in Nova Scotia for unattached patients, it basically found in the qualitative results that pharmacists played a critical role in providing primary health care to the growing number of unattached patients. When it comes to our SWOT analysis, we don't really have time to go through it robustly, but just a couple quick highlights. We really found that the peer support was felt to be essential for the community pharmacists when expanding their scope of practice. And this was both in the form of the vaccine consult service and the non-severe pharmacist consult service. And they also really appreciated the multi-stakeholder communication and interprofessional collaboration that went on throughout the pandemic. In terms of weaknesses, we certainly appreciate the community pharmacists wear a lot of hats these days, and having multiple roles can really make service provision challenging. When it comes to opportunities, we're already starting to go down this pathway, but where we've seen this expanded scope work really well for the pandemic, we're exploring what that can look like for other forms of primary care and basically how we can maybe change the way pharmacists are practicing outside of traditional pharmacy settings. When it comes to threats, understandably, we have a lot of people retiring from healthcare right now, including in the pharmacy profession, and burnout is a real threat. So we want to make sure our pharmacists feel supported. And then just really wrapping it up. So we were able to expand our scope of practice based on changes that happened through both Health Canada and provincial legislation and our standards of practice. We feel it's really essential to have government reimbursement for our services to facilitate their uptake. And otherwise, I'm more than happy to answer any questions that you have.
Thank you, Tasha. And I'm going to turn this back over to Sarah to moderate any questions that we might have remaining. And actually, Sarah, I do have one. Should I go ahead? So just curious to ask maybe several of our presenters, pharmacists clearly played a critical role in COVID-19 vaccinations around the country. Why was it decided not to engage primary care practitioners in COVID-19 vaccination, since they often do a great deal of vaccination in the context of their regular practices?
I can maybe speak specifically to what we observed in Nova Scotia. I can say in our planning groups that we certainly did consult with, traditional primary care providers, including nurse practitioners, family physicians, and more. And it was really just determined at that point there was a tremendous backlog in their appointment volumes. They had to shut down during different periods early on in the pandemic when there were lockdowns. And when we really looked at what they could be doing with their time, what they were often expressing as well is that it was felt to be more useful and there was more high yield activities and catching up on the backlog. And they had so many patients trying to get in for, urgent care from having been delayed basically for so long during the pandemic. At this point, I can say in our vaccine campaign, we do have some involved in this respiratory season. So they're starting to come back into providing them in Nova Scotia. But in those early days, it was really just felt that they were going to focus their activities, on other things.
Nancy, did you want to weigh in on that question?
Excuse me, I didn't understand.
Would you like to also answer the question around primary care and their role in vaccinations generally?
I'm not sure in Quebec. I didn't look at this particular for the vaccination, so no, I'm not. I can't answer. Sorry.
Thanks so much. And yeah, and I guess Tiffany, did you want to mention anything based on the comparative work?
Yeah, I mean, we didn't dive into specific reasons why, but we did see there were clear differences in the degree to which primary care was involved and like how early on that had happened across the provinces.
Thank you. And Cheryl had a final question, I think.
Yes, a follow-up to the response that Tasha gave Dr. Berman, which is, and thank you for the data you shared in your presentation. Some of the data was around how many Nova Scotians were served by community pharmacists during COVID. Did you survey citizens in Nova Scotia about their experience with community pharmacies and how they may use them going forward?
Not in particular, but I think that'd be a really interesting focus moving forward. We also are really interested in exploring equity and reach of our programs just to see if there are opportunities for improvement in the future. So certainly hoping to do some further follow-up work there.
I'll look forward to that.
Thanks. Emile, any final comments since you haven't had the chance to respond to any of the questions about primary care or about sustaining some of the changes that you documented in your paper, maybe going beyond COVID into the future?
Yeah, I think there are a number of pieces of the system that, and tertiary connected pieces to systems that work well. There's people that do outreach with marginalized groups that you can rely on and should early on. Primary care became involved in our clinic in May of 2021, and that was really late. But it was a good help because there was a lot of resources that went into changing how we did some of the bookings and developed our own booking system in the community and worked with community health centers. All those pieces, I think, need to fit together and can if we engage them in ways that recognize and appreciate and value how they can work together and be effective.
Thanks. That's actually the perfect, and the timing is right, but also the perfect note to end on. And I really appreciate all the presentations today. Thanks to Peter and to Cheryl for moderating and for introducing our presenters. And please do read the papers and check out the Health Reform Observer. Please stay tuned to the Institute for Pandemics social media and upcoming newsletters, and we'll welcome any questions to any of us at any time. Please stay in touch, and thank you again for your time today. Take care. Thank you.